Dr. Santosh Bide, Dr. Mahesh Babu, Dr. Sudipta Mitra, Dr. Niladri Saha, Dr. Somen Mishra, and Dr. Omkar Telang. With that, I request the co-chairperson, Dr. Manvi Sindhal, to kindly conduct the rest of the proceedings. Thank you.
Can we start with the first speaker, Dr. Ayesha?
Yes, ma'am.
Yeah. And can we have the next speakers ready for this?
Dr. Ajay Arora is the next speaker.
Yeah.
So good afternoon to all present here today. I would like to express my thanks for this opportunity and the stage. So today I am speaking on reducing treatment burden in retinal vein occlusion, applying acquired knowledge of aqueous biomarker profile. So briefly on retinal vein occlusion, the primary event is the obstruction of retinal veins, usually by a thrombus formation. Post-obstruction, there is raised venous pressure, hypoxia, increased in capillary permeability that results finally in macular edema. Numerous studies have proven the role of anti-VEGF and steroids for treatment of macular edema in RVO. Aqueous profiling of treatment-naive RVO have confirmed the presence of both inflammatory and angiogenic process, establishing it to be a complex interplay of both processes. In our study, we did a blanket suppression of both by giving combined anti-VEGF and steroids. We also studied the aqueous humor profile of all the patients. The results of our analyses showed that patients receiving combination were more likely to achieve the target BCVA earlier compared with the patients receiving anti-VEGF alone. The combination therapy offers a greater reduction of CMT, and the greatest advantage of combination therapy is that the number of injections is reduced and fluid-free interval is much longer in combined. That's not all. Along with noticing significant reduction of CFT, the likes of which won't be seen with the monotherapy alone, our cases also showed us a variable soluble biomarker profile, and that's where the limitation of a study also lies in. What we did was a blanket suppression of both processes without understanding the dominant driving process behind the edema. It was like giving empirical antibiotic therapy for all the infections. But what it helped us? It did help us in understanding the disease better and how in the long run this would pave the way for more tailored approach. Like for this case example, where the driving process is inflammation demonstrated by raised IL-6 level, giving anti-VEGF in this case scenario would not have been fruitful. What we have discussed here is just one of the applications of biomarker profiling to the clinics. In future, it opens up the way to multiple eventualities. It offers the opportunity to stratify patients based on their molecular profiles, where they can be categorized into subgroups with varying disease severity and progression rates. By tracking changes in biomarker levels over time, clinicians can identify early signs of treatment resistance and disease recurrence, enabling timely interventions. So, with deeper understanding of molecular characteristics of disease, we can develop personalized treatment plans that also takes into account individual variations in biomarker. So, this bespoke approach optimizes treatment outcomes by selecting the most effective interventions for each patient while minimizing adverse outcomes and reducing treatment burden. There is potential to reduce overall healthcare costs associated with the disease by optimizing treatment efficacy and minimizing unnecessary interventions. So in summary, aqueous soluble biomarker profiling transforms the treatment paradigm by enabling a more bespoke approach to individual molecular characteristic of each patient. So what this presentation shows you about applying the labs to the clinics is just the tip. There is this whole iceberg of multitudes of possibilities still waiting to be explored. Thank you.
So what are your proposed clinical applicabilities of this methodology?
So So, ma'am, as we have seen, first of all, whether when we are collecting the aqueous sample, it helps us to determine whether the edema was inflammation-driven or angiogenic process-driven. In that way, we can decide whether we want to go ahead with anti-VEGF or steroid. And usually what we have seen if the primary macular edema is because of inflammation, the next time when the patient again gets edema, it would be mostly because of inflammatory markers itself. So next time we can plan to go ahead with steroids rather than going for anti-VEGF. This is the one thing. And now we have come up that case example we've seen where IL-6 was high. We have seen case examples where ICAM-1 was high and all these things. So we are in the process of developing particular, like specific ICAM inhibitor, LFA1 antagonist and everything, which will particularly go and suppress that one thing, and that would actually address the exact biomarker responsible for the whole problem.
Have you tried correlating it with OCT or OCTA?
Oh, yes, ma'am. We are doing it, although what OCT features, what OCT biomarkers correlating with what aqueous biomarkers, if this is high, if we are seeing that and that. So all these correlations are going on simultaneously.
Thank you.
Thank you so much.
Next, Dr. Ajay Arora, sir. Over to you.
Thank you, ma'am. Thank you, chairpersons and honorable judges. Can I have my... Yeah. So I'm presenting on to evaluate efficacy of centrifuge triamcinolone in suprachoroidal space in macular edema. Part of this work was done at the SEM lab at IIT Delhi. We know that suprachoroidal space is a potential space which is located between the outer layer of choroid and inner layer of sclera. Its potential and hence it's difficult to reach this space. You need proprietary microneedles. So there are various microneedles available, but Clearside Biomedical microinjector system and a jugaad which is created by combining a 23 gauge and a 30 gauge needle. But this has got its limitation and manufacturing problems. So we decided that can we use a normal 30 gauge needle and inject through a device. So you can see here we did some animal studies initially, and this device is being used to inject triamcinolone into the suprachoroidal space using a normal 30 gauge needle. And this we have now done in 128 eyes. So this was the initial patient, a 58-year-old obese female who had persistent diabetic macular edema, had received multiple anti-VEGF injections on Ozurdex, and when Ozurdex was not available in the country, she came to us and we decided to inject triamcinolone into the suprachoroidal space after the due consent. And you can see here beautifully on the 14th day the macular edema had reduced, and this lasted till 88th day. So then we decided to extend the time for triamcinolone by centrifuging and removing the supernatant and injecting the pellet inside the eye. And we had 16 eyes of 14 patients which were taken. All underwent centrifuge injection of Skeeter of 0.75 to 1 ml. They were put on topical anti-glaucoma drugs for about 2 weeks. One patient required a filtering surgery. There was no retinal-choroidal injury, and the edema came down in 7 to 30 days and remained edema-free for about 80 to 158 days. This is an example of a patient with vitritis, with patient of tuberculosis. Skeeter was given. The vitreous cavity cleared up. Patient's visual acuity improved. This patient was a non-infectious uveitis. We gave a normal standard triamcinolone. The effect lasted for about 4 months. You can see how beautifully the edema is reduced and the visual acuity is improved. The same patient we injected centrifuged triamcinolone, and you can see here that the effect lasted for about 8 months, which is 5 months more than the Skeeter. There is no drug available at this point of time anywhere where the effect lasts for 8 months. Imagine having just 2 injections in a year. The same patient we subsequently gave 1 more injection, and this effect lasted for 7 months. So if you compare the economics and environment friendliness between Ozurdex and Skeeter, the country will be saving about 149.76 crore rupees annually if they used only Skeeter. There is also minimal plastic utilization, and in case we use the centrifuge triamcinolone, this saving can become 250 crores. So I'll conclude that suprachoroidal injection of triamcinolone is a safe method, and it is not only that it saves a lot of money, it is environmentally friendly. Thank you.
Sir, it was a very nice presentation. Sir, did you face any complication like perforation in the method that you followed?
So the only complication which happened initially was that the injection, instead of becoming suprachoroidal, becomes intravitreal. Because we're injecting at 4 millimeters, 3.75 to 4 millimeters from the limbus. So that's a complication which we anyway give an intravitreal triamcinolone, so that's not a complication at all. But I was afraid of creating a choroidal hemorrhage, but that did not occur. And now that we have, now I've taken it to the next stage where actually there will be an electronic signal the moment you go into the suprachoroidal space, but that is not part of this presentation.
Okay, that's great, sir.
Thank you, sir.
Thank you.
I would like to call the next speaker, Dr. Narendra Singh Verma.
Yes. So we did UBM analysis on these patients. It's very surprising that once we inject the drug, and so we did animal studies and then we did human studies. Within 45 minutes, we are hardly able to detect where how the drug has spread all over the suprachoroidal space. So on a UBM also it is difficult to detect. It becomes such a thin sliver. Then we went ahead and injected methylcellulose and halon into the suprachoroidal space in animal studies where we could expand it. That also gradually settles down. The triamcinolone is such a thin sliver that you can't make out on UBM. I cannot see it on an indirect any mount anywhere. Thank you.
Request the next speakers in line also to be ready.
So good afternoon, all the seniors, experts on the dais, and my dear friends. I present to you this SI calculator. If you want to measure your centroid SI, you need not to go on Dr. Warren Hayes SI calculator. So, audio. Good morning, everyone. I present to you SI calculator, which can be accessed on mobile also. The limitations of present SI calculators are
Presentation is not showing.
laptop or desktop, can be accessed by the members, some are paid. Good morning, everyone. I present to you SI calculator, which can be accessed on mobile also. The limitations of present SI calculators are they require laptop or desktop, can be accessed by the members, some are paid. The registration process is very tedious. They calculate SIA by vector method only. Data entry and evaluation of results is not user friendly. Comparative analysis of different type of incisions is not possible. You have to fill different data sheets if you want to compare different type of incisions. SIA calculators are used to measure mean SIA and centroid SIA. For astigmatism correction during cataract surgery, mean SIA value will decide the size of steep axis incision, and centroid SIA value is used in the toric calculators. Incision on the cornea causes change in cylindrical power. There may be steepening or flattening. At the same time, rotation of the steep axis, which may be clockwise or anti-clockwise. So an ideal SIA calculator is one which can predict how much cylindrical power will change, as well as how much rotation of the steep axis will occur and in which direction. But the present SIA calculator, which are based on vector method, can measure only the magnitude, mean SIA and centroid SIA. They are not designed to measure the rotation of steep axis. The polar method can measure both magnitude and axis rotation. In vector method, we measure SIA by this simple formula. In polar method, SIA is measured in two parts, which are called polar vectors. One measure the change in the cylindrical power and another measure the rotation of the steep axis. Root square sum of the two parts of polar SIA is equal to the vector SIA. So polar SIA tell us how much SIA part is changing the cylindrical power and how much SIA part is rotating the steep axis. This SIA calculator provides SIA by both polar and vector method. Access is very easy. Scan the QR code, log in with your ID and password. There is single input data sheet for all type of incisions, FACO, SICS, LRI, etc. All the results are provided on single screen. The results include vector SIA, 2 parts of polar SIA, axis of rotation of steep axis, coupling ratio, and change in spherical equivalent. In the lower table, you will get mean, median, quantile, and standard deviation of all the results. This is centroid SIA by vector method double angle plot. It is similar to Dr. Warren Hill SIA calculator. This is centroid SIA measured by bivariate analysis of 2 parts of the polar SIA. For validation, we have compared our 10 results with Dr. Warren Hill SIA calculator, which is based on vector method, and Dr. Neil Alpine AIOC SIA calculator, which is based on polar method. The results are same. Comparative analysis of different type of incisions and other parameters is very easy. This is an example in which male more than 60 years, when incision is 1 millimeter away from the limbus, 2 to 3 millimeter in the size, and having with the rule astigmatism is compared. The system will automatically select the data and provide results automatically. So this SIA calculator is free to use, easy to access by QR code, and can be accessed on mobile also. Calculate SIA by both polar and vector method. Data entry is easy in a single Excel sheet format. Results and graph are displayed on single screen for easy evaluation. Comparative analysis of different type of incision is possible. Thank you. Thank you. So this is the barcode. It is free. So that's you just scan the barcode. In the mobile you will get the, you can access the SIA calculator directly.
So when are you assessing it? After how many days post-operative?
1 month.
In all cases, it was 1 month later.
Yeah. So the advantage is that in all type of incision, you can enter all type of LRI, AK, whatever is there. So single data sheet is there. Then you can compare. You can choose the which incision you want to compare. SICS, superior, temporal. So in the Warren Hill, you have to fill for 5 millimeter. You have to fill another data sheet for 6, another. So that is very, and you will get access of one. One ID will get access of one person will get only one access. So Dr. Boramani, he was saying that I have to compare 5 millimeter, 6 millimeter SICS incision. That is not possible. So here you fill the data. You can fill the data on the mobile also in your OPD. So no need of laptop, desktop.
Very good.
Yeah, you have to sign.
First, you have to scan the QR code.
Yeah.
And the data be recalled.
Yeah, first you have to scan the QR code. You made your profile. There is profile. You made your profile. Then you can enter data, and then you can see the results.
Yeah, agree. But
Yeah.
most of the time, once I'm out of that window,
Yeah.
can I have to scan the?
No. That window is open in the mobile. You can keep the window open in the mobile.
On that.
It's not like an app.
No, it is
It's a
not
web
like
page, yeah.
Yeah.
Close the window.
Yeah.
Then I lose it.
And then if you open this, then you have to enter your ID and password. Then the same data will open, whatever you have entered.
It is saved.
It is same. It is saved for your ID and password. So we can see it, nobody else can see. We can see it.
Can I call upon Dr. Rita Hepsirani for the presentation?
Good afternoon to all. My topic is efficacy of injection Botox in hemifacial spasm. So it is a chronic neurological disorder characterized by short, involuntary, frequent, clonic, tonic contractions or twitching of the muscles innervated by the facial nerve. It is usually unilateral. There are 2 types, primary and secondary. Primary, the most common etiology being vascular loop causing compression of the facial nerve. Secondary causes are tumors, demyelinating disorders, injuries, infection and brainstem lesion, etc. So here few movement disorder. Whenever there is movement involving the orbicularis oculi muscle, it is called orbicularis myokymia. So whenever it's involving half of the face, it is called hemifacial spasm. Whenever there is both the auricularis oculi is involved, it's called essential blepharal spasm. And whenever the BEB plus lower half of the face is involved, it is Meek syndrome. Whenever it is along with the neck muscles involved, it is called the Bruegel syndrome. So the mechanism of action of Botox injection A is, so there are from A to G it is available. Commonly used available form is injection Botox A. So it acts in the presynaptic nerve cleft and it enters the cleft by endocytosis, and there is dislodgement of the light chain and heavy chain occurs, and the light chain interferes with the snare proteins and prevents the acetylcholine receptors release to preventing the muscle contraction. Aim of the study is to determine the therapeutic outcome, efficacy and adverse effects of injection Botox in hemifacial spasm. Study design is a prospective cohort study conducted in the Government Medical College in Tamil Nadu. For study period, it is followed for 5 years. So all the patients were with hemifacial spasm after getting the neurological opinion were included in the study. So after collecting all the socio-demographic details and neuro-ophthalmic evaluations, and MRI brain was taken to rule out the primary cause, that is the vessel compressing the facial nerve. And reconstitution of the injection Botox is available as a powder in a compressed form. It may be available in the 50 international unit or 500 international unit. So 4 ml of 0.9 normal saline is added and dissolved gently so that each ml contains 25 international unit concentration. The typical dosage for injection Botox is around 20 to 40 units per site. Method. So it is loaded in a 1 ml tuberculin syringe with a 30 gauge needle, and it is ready for injection. So by marking the visible areas of twitching, injection Botox A can be injected. Follow up for weekly for 1 month and monthly for 1 year and 6 monthly for 5 years. Patients at each visit, they are screened for persistence of symptoms, recurrence and side effects such as dry eyes, lag of thalmus, ptosis, bruit and deviation of angle of mouth, etc. So in our study, 80 patients we gave injections, and commonest age group is around 51 years. And it's more common in female, it's common in left side, and it's mostly unilateral. So systemic commonly associated illness is hypertension. And so most commonly the area involved are eyes, nasal fold and mouth. And the peak effect is obtained during the second week of the after giving injection, and the duration of efficacy stays for 5 to 6 months. In few cases it lasts for 7 to 8 months also. So the commonest side effects are bruit. So it is overcome by making use of 30 gauge needle with a single prick, and after giving the injection it is compressed with cotton soaked in cold saline and dry ice. So it is avoided by giving injection away from the muscle of riolan, and lag of thalmus is very most common in our study. Compared with other studies, ptosis is very common. It causes most some cosmetic disturbances. This is because we are giving the injections the preseptal part of the orbicularis oculi instead of the pretarsal part, and deviation of mouth and ptosis and persistence of symptoms are there. So these were my reference, a short video. So here we are using a 30 gauge needle little away from the eyelid crease. That is a preseptal part we are giving. Because if you are giving perpendicularly, the LPS is involved and cause ptosis. But here initially we had 3 cases of ptosis, but it is avoided by placing the needle horizontally. So the ptosis, we didn't get any ptosis as a complications. So this is a superficial muscle. While giving the nasolabial fold in zygomatous major and minor, we can give the injections in the vertical manner. Thank you.
How long does the effect last?
So most of the cases it is around 4 to 5 months, madam.
And then you repeat it?
Yeah, repeated injections. That is one of the scientific.
Thank you.
Otherwise, the patients are very happy.
Thank you, ma'am. Can we have Dr. Atul? Dr. Anoop, if you are present, please be ready.
Good afternoon, seniors and my dear friends. I would like to talk to you about C-Blue, Cobalt Blue Light Unit, revolutionizing point-of-care diagnosis of corneal diseases. As we know, we stain the eyes with fluorescein stain, and if we have a photo slit lamp, we can take photos of the eye after switching on the cobalt blue filter. The blue light is emitted, and then we can capture the photo. But what if you don't have a photo slit lamp? For example, in emergency ocular trauma, in ICU in chronic bedridden patients, in infants, if you want to photo document their corneal lesions, or in eye camps, you don't have a portable slit lamp. So how do you photo document these cases? So we thought to ourselves, what if we have an attachment for a smartphone that is low cost? Anyone, including doctors and MLOPs, any health assistants can use it. It should be portable, pocket-sized, and easy in handling. And the quality of the image obtained should be reproducible and good, and should tell us stain positive or negative images. So with this in mind, we opened up a slit lamp and we studied the blue filter in detail. After research and development in 2019, we developed the C-Blue first version, which was called as a C-Blue adapter, the details of which was published in IGO under the innovations, and it worked on the principle that a cobalt blue filter is introduced in front of the flashlight of a smartphone, which filters all the lights except the blue light, and which will give fluorescence of the patient's cornea. We used this to photo document an infant who had pseudomembranous conjunctivitis, and we could see how the lesion was healing with time and with treatment, and this was published in the IJMR. And in 2021, we came up with a blue patch. It was a bindi-sized small sticker type attachment that could stick onto the flashlight, and it was a disposable version. So whenever you want, you can stick it onto the flashlight, and you can take photos just as you see here. But we thought ourselves, we want something that is more universal, more smaller and cost effective, and we want it to be reused. So in 23, we came up with this latest version of C-Blue, which you can see here, it follows the same C-Blue principle. It is made from acrylic material and is laser cut into precise circles. We take the C-Blue out of the packet that is provided, and then there is a sticking part which we peel off, and any smartphone, Android or iPhone, can be used, and you keep it on the flashlight, and with a gentle pressure it gets stuck onto the flashlight. Now after staining the patient's eye with fluorescein stain, you switch on your camera, you can use a regular video mode and capture photos through that, or you can go into the native camera mode itself. This is the video mode that is being done, and you can take with a normal photo mode, in which you can take the flashlight, the photo. This is a C-Blue photography. You can see the image that is being captured. This is a simple C-Blue photo. So these are the lesions that were captured using the C-Blue adapter attachment on the flashlight. And pilot testing was done in 34 patients, and a 5-point Likert scale was used for user feasibility, and the images were graded by blinded subject experts, where 1 was best and 5 was worst. So 30 users said it was very easy, whereas the expert graders gave it 1 and 2 points. And we have received a grant from Seva Foundation, in which we have already implemented it in vision centers. We have taught sisters how to use it, and these are the images captured by the sisters.
Stuck.
Sorry for the delay. So I believe we can train healthcare staff with minimized specialized training to use this device to supplement and promote healthcare communication and efficiency. It is a very simple, inexpensive, portable solution with a quick learning curve. Thank you.
What is the cost?
Right now, the cost we have come to is around 100 rupees, ma'am. We are trying to bring it down to 50 rupees.
Is it commercially available?
These are samples which I have given. We have not started selling it yet.
Okay.
The patent process is pending. So once the patent comes through, we are planning to make it commercially available.
Okay.
These are the samples which I have brought.
These are disposable.
It is reusable. So what we can do is the sticky part, the sticky film, we'll be providing multiple sticky films with this. So once you are done, you can take it off and then use another sticky film on it, and then you can stick it back. So since a sample, I have provided just 1 per piece.
Okay.
Pardon, sir?
How many times can we use it?
So it depends on the number of sticky films you have. So once you have it and you would replace it back, then it's just like we have not tested how many times one film can be used, but we'll be providing at least 50 to 100 sticky films along with one packet itself. It is a very small, it is not expensive at all.
So if we take out the films, the blue filters, can we take the normal picture with it?
Yes, sir.
Okay.
You can always use a phone as it is. Only when you keep this, you can use it as blue photography.
Okay.
The phone is left intact. No damage to the phone whatsoever.
Blue filter is polythene, no? What?
Pardon, sir?
Blue filter is made of what material?
So this one is made out of acrylic. The ones we have in the microscopes, in the slit lamps are made out of glass. But it's very difficult to cut glass into the small size. We have to grind the glass. It will cause breakage of the edges. So we have laser cut acrylic material to achieve the same effect.
Thank you.
Thank you.
Dr. Anu.
Good afternoon, everyone. Moving on to the next presentation. It is also, can I get the slide? Yeah. So it's again in development stage. I am presenting before you AP chopper or maintainer. So going straight ahead, first with the design, it will have a normal irrigation for phaco tip, but it will have a single opening, and the opening will be towards the center to avoid the fluid disturbance to the iris. And it will have an integration of the chopper as well, so that we don't have to change hands or change instruments while we are doing phacoemulsification surgeries. And in simultaneously, it will chop also the nucleus, dialing and everything, and also it will act as an irrigation cannula. So this is the second design way of the tip of the chopper. That was a ball tip, and this one is a little bit sharper edges. So we'll go ahead with the video. We'll have a video demonstration demonstrating a normal irrigation port can also be used for chopper. Here I am doing a capsular access with the same irrigation cannula, and it is very comfortable. As we can see, we can use it through the side port, and I have demonstrated it in intumescent cataract so that we can analyze and access how is it working for the complicated cases as well. So it is very convenient to complete the access also. We don't need to change hands, and we can directly go ahead inside with the phaco probe, and we can also chop simultaneously. Here I have demonstrated that even though this tip doesn't have a chopper, but still we can see how efficiently we can chop if we have a better grip and a little bit of alignment. So rest of the surgical things are as smooth as a normal chopper. Here again I am doing with the simple PSC, posterior subcapsular cataract, with almost no nuclear content here. So again here also we can see that using that chip we can also get a crack. And it is also safe because the irrigation fluid will further push the posterior capsule behind. So the advantages of this instrumentation is that there is minimal exchange of the instruments, less visco usage, it is cost effective and can be autoclaved. It can reduce overall surgical time and have a better control and AC maintenance. Thank you for your time.
What is the thickness of that chopper?
Sir?
Thickness?
Sir, it around 0.2.
So it can go through 20 gauge side port, or you have to have a bigger side port?
No sir, it can't go through it. We have to just elongate the tip of the average irrigation cannula and make it blunt.
So you have used the same irrigation cannula and
yes, sir. In the irrigation cannula itself, there will be single port for the fluid, and the tip will be elongated a little bit and bend over to form it into a chopper, sir.
So two irrigation lines are there.
Yeah. Sir,
one in the handpiece and this is an
yes,
extra.
But the thing is that this we will be connecting through the IV line into the bottle, so it will act according to gravity. So if there is a sufficient pressure inside, then the fluid through this irrigation cannula will stop.
Why the irrigation then?
Why the?
Yeah. I mean, what are you getting? You have a chopper and you have irrigation through your phaco probe. Why have an irrigation?
I am not restricting the use of this only during the time of chopping. I am talking about moment during type of capsular access as well, and in between surgeries when we will be putting viscose in frequently.
When you are changing instruments to keep the globe bent.
Exactly.
But then we have...
Yes. To reduce the usage of viscoelastics in between.
We do have in modern machines where it maintains the irrigation flow.
But that's costly.
Yeah, that's definitely costly, but then this instrument is again costly, right?
No, it
Have,
is a-
have you
anyway
already
we will have
commercialized
a-
it?
anyway we
Have
will
you
have-
commercialized it already?
No, not yet. But
Not
anyway,
commercialized.
whatever we are...
So it can be used with all machines?
Yes,
with all
ma'am.
type of
It is just like
fluidics?
an extra hand, just like an extra chopper, but just because of modified design, we have to
Because
connect
see,
an IV
the
line.
aspiration or whatever fluid you're putting in, it actually, the whole fluidics plays on that.
Yes, ma'am.
So when you're putting an extra bit of fluid, actually, when the AC is not being maintained, you're giving the extra irrigation,
Yes,
right?
ma'am.
That's what you wanted
Yes,
to mean.
yes.
That by gravity, that will automatically. So does it have a sensor to detect that? How will it? Just by gravity?
No, if the chamber is too tight already, then the fluid circulation will stop.
So it is just like a irrigating chopper. That's
Exactly.
it.
Yeah, it's like.
So that's nothing. Yeah, irrigating chopper. It's a irrigating chopper. That's
It's
it.
not
Yeah,
that
thank you.
detect that the AC is collapsing.
Yes.
so let it
We can modify it over time and we can implement that. Yes, sir.
This would be that you will need two balanced salt solutions,
Yes, sir.
two IV sets or whatever, all
Yeah.
double.
Yes.
All double. The
Rather
cost
than
goes up.
cost cutting, I think you're increasing also simultaneously.
But sir, I think overall cost, if we considering the viscoelastics, and moreover than that, during the time of
balanced salt solution
surgeries,
is more expensive than a
Then we
Yeah, viscoelastic is less. Yeah.
many of the times changing hands and instrument, the time crucial considerations should also be taken into mind.
point taken.
So at
Thank
the,
you.
Thank you so much.
At the time of Faconit, a lot of multiple, these are choppers was there.
I think Dr. Vaibhavi Patel and Dr. Vignesh are not here. Dr. Pushkar Dhir. And do we have Dr. Kshitij? Next.
Eye doesn't see what mind doesn't know. But what if we show something to the eye and mind doesn't read it? Isn't it an amblyopia? Yeah, I am Dr. Pushkar Dhir, and that's the end part of it because you've given us a less time. So while I was a kid, I have a limited knowledge, and I was always thought that this photograph was symbolic of being a pirate. But when I got into PG first year, I realized that no, it's a patching. But as soon as I came to my end of third year, then I realized that it's not patching. It's actually, he's an adult, so it's not patching. It's again a symbolic, where pirates have to be in a state of constant state of war and they have to move up and down the deck, so they need to cover one eye always. So amblyopia interest was always there, and since that, because of that, I am here to present my say on amblyopia. So amblyopia has been passively and actively treated. Passively, where there is no conscious visual stimulation is given, and in actively there is a visual task which provides a positive feedback. So when we talk of passive, we have the refractive correction, atropinization, and patching. Patching has stood the time tested and is still very much in use, but what we see with different kids, and a problem with different kids, that they are non-compliant with the patching. They tend to remove patching. Even for a certain period of time, they start removing the patches, and that also lowers the self-confidence in them. So different studies have shown that there is almost 50% of compliance with patching and other problems related to conjunctivitis, mucopurulent conjunctivitis. So we needed something which treats amblyopia and helps to gain the depth of vision. We needed something which is binocular, treats amblyopia and keeps the kids happy. So in 2018, AIOC came up with VHAT study, where we had done a virtual reality headset in amblyopia treatment, where a simple virtual reality headset was used. A video was used in which one was blurred and other was not. Earlier we used to put a screen on it, but now I have made different videos where one is blurred, which is shown to the good eye, and the lazy eye is shown the clearer version of it. It was very cheap. Though it didn't come up that well in that session of 2018, it was taken up that VR headset was used for perimetry. I still remember that speaking under Apple Tree won that, the VR with perimetry won that prize at that time. So the concept behind lazy eyes was that we are not able to see the clearer vision. So the goal is to simulate fovea as much as possible with best possible focus. Realizing that, I went back and saw that vision has so many dimensions: vision, color vision, contrast, visual field, binocular fusion, 3D perception, stereopsis, adaptational property, Troxler effect, and so on. So color vision, in this picture somebody will see a photographer, an old man, somebody will see a village with the trees and ship. In this photograph, some will see moving lines coming out, and then some will say it's a straight line. Some will see Narendra Modi, some will see Manmohan Singh ji in this. Some will see me in this, some will see Jackman in this.
So we have our eyes having a different effect. This is a Troxler effect. If you focus on 2-3 seconds in the central cross, the side starts going, the side color starts going. So what I realized that we can use the polarization effect, which is one of the unexplored effect which our eye has. Why not to use this concept and try to stimulate the eye? So our eye is capable of seeing a polarized light. So if polarized light is passed through a dichroic substance, it will get into linearly polarized. And fortunately, our eye has pigments in our Henle cell layer, that is the photochromatic rods and cones, which leads to a dichroic effect, leading to a phenomena called as Hardinger brushes. So this is present in our eye but not usually seen because of our adaptive properties by the brain. So if we start giving more and more Hardinger brushes to the eye stimulation, we'll start seeing it, and we will start probably massaging the fovea, increasing the vision per se. So we did this study at our hospital. It is still in preliminary stages. This is a synaptophore which is now made by Baliwal and all only. So we give the stimulation, continuous stimulation of blue polarized filter through which the light is continuously coming, and patients tend to perceive a proper Hardinger brushes effect. So we have seen in different cases, aged from 19 to 17 years even, while the emblepic study was still 7 years, that we have seen a significant improvement in the vision in such cases. So this is a forgotten remedy, and it is not something which is AI based or something, but yes, it was there previously, and I wish to insist that it can come back and do a more bigger effect. The future is what I have kept in front of you. The future is coming here, and it's already been there. That is the Apple Vision Pro, where you can see the people in front of you and still you can use the mobile like this icons. So this is the future we are seeing, and I think there are so many softwares which now can be made up, taking the concept of polarized light into the VR system headset. So that was my concept behind speaking on this under Apple Tree. Thank you very much.
It is more or less entoptic phenomena.
Yes, it is an entoptic phenomena, but we have used one particular dimension of light now, this time the polarization effect, and we have seen
so
a
how
significant...
it stimulates?
Yeah, it's the stimulus.
No, how?
Yeah, so this synaptophore has a device called as a Hardinger brushes. We all know the simultaneous macular perfusion slides are there, the monocular perception slides are there, but we never tend to go to the Hardinger brushes slides. So if you put it, it's a rotatory device through which the normal white light passes through a dichroic filter, which is a blue filter, and then when you focus it on the eye, slowly, gradually, you will start seeing Hardinger brushes phenomena inside your eye. And what we have done recently, for past 2 years, what we have been doing is we tend to give children who are anisometropic amblyopia, we give them a 2 weeks of therapy, followed by 3 months follow-up, and we have seen a significant result in these cases. And I will publish that in future. We have already published in ACTA ophthalmologia, but that's not a high index journal. We are collecting more of data to publish it in the IGO in the future. Thank you.
Yeah, very good afternoon to all. May I have my slides, please? So I'm here to talk about my paper titled Direct Endoilluminator Assisted Surgery for Retinal Detachments, its clinical and anatomical outcomes. I don't have any financial disclosure. It's a very simple modification, and as we all know that scleral buckling is the basic surgical treatment for treating rheumatogenic retinal detachments, and here observing the retina is very essential. And this has been routinely done by using an indirect ophthalmoscope, and as we all know that doing an indirect ophthalmoscopy requires some amount of skill, and it has got a learning curve. And even after you have mastered it, while you are performing scleral buckling, because of its repeated removal and application, it becomes inconvenient and time consuming. So over the past decades, few papers have come up with this modification where they have used wide field viewing system along with 25 gauge or 27 gauge chandelier illumination to overcome the inconvenience of using indirect ophthalmoscope. However, the unmet need still remains because of the fact that this chandelier illuminator is, the tip is quite small and it may not highlight the region of interest. And also, since it's connected to a fiber optic cable, if your assistant is not holding it securely, and it may inadvertently move during the surgery and may hit the phakic lens or the tissues inside the eye. So I came with this simple modification where instead of the chandelier endoillumination, I'm using the endoilluminator probe directly along with the wall trocker system, along with the wide field viewing system.
So if you see here that in this case, the detachment was in this quadrant, so I'm applying the trocar cannula in the diagonally opposite quadrant, and once this wall 25 gauge or 23 gauge port has been secured, then you just bring in your endoilluminator, which you use routinely for your vitrectomy, and swing in the biome, and once you enter inside, you'll get a panoramic view of the entire retina, and you can go into the to the far periphery and the deeper depths of the retina, and you see here the break is getting indented, and then the cryo is being applied, and you can do all these things while you are sitting comfortably in your driver's seat without the help of any assistant. Everything is being controlled by you, and some of the videos over here, you can see that in this video we are applying the trocar in the diagonally opposite quadrant. In this video you would see the indentation, and one can go very close to the retina to get the thorough view of the break as well as the detached area. And in this video, if you see, the break was in the supratemporal quadrant, so I secured the trocar in the infranasal quadrant. So you can just play around depending upon the quadrant or the region of the interest where you want to get the area highlighted. So another application of this endoilluminator technique would be in the drainage of the subretinal fluid. Normally what we do is, we do an external stab puncture, and this procedure at times is blind. So what one can do is that after going inside, and then you insert the needle, and then you can see in this video that you are draining the fluid under direct observation. So again, it becomes an endoilluminator assisted surgery or the passive drainage of the subretinal fluid will happen over here. You can see the needle is going in the subretinal space, and you are observing everything with the endoilluminator, and this passive drainage happens. And you see the SRF gets collected. And towards the end of the surgery or the buckling technique, you can use it again, go inside and check the adequacy, the height of the buckle, as well as the patency of the central retinal artery. With this, I come to the data pertains to 26 size. I have done in 26 cases so far. The best corrected visual acuity was 20/40 or better in 10 eyes. Myopia was present in 15 eyes and -1 to 1 8 diopter range. And the phakic status was in 22 eyes. The number of retinal breaks, 3 or more holes were present in 5 eyes, and this is one case example where you can see that by 6 months, as with any other buckling surgery, the outcome is very good and comparable to any of the buckling techniques. Thank you.
So what you're doing here is, instead of having a chandelier, you're just using the endoilluminator,
Yes, ma'am.
which you're holding with your own hand.
Yeah, and everything is being controlled by the surgeon
So
itself.
I think even if you had you said the disadvantage of chandelier is if your assistant doesn't handle it properly, it can touch the lens.
Ma'am, but
You could move it yourself, and an endoilluminator and touch the lens. An endoilluminator from the inferior nasal quadrant while trying to do cryo superior temporally is going to be quite an awkward thing. I mean, it may work well with you. And also, the chandelier has a very small tip which protrudes into the eye.
Yes, ma'am.
In your own video, I could see that the endoilluminator was quite inside, and we are not doing a vitrectomy here, so you're going to be disturbing the vitreous
Yes, ma'am,
further.
but towards the end, what I do is once you are taking out the illuminator and removing the port, I cryo the port.
Port also, but
The
you
port
have
also.
still removed the vitreous around inside. So yeah, it could, because you have gone in more into the globe.
Yes, ma'am. So far, I have not landed up in complication touch. Thank you.
I mean, it's a great jugaad when you don't have your chandelier available,
Exactly.
and you shouldn't be in a fix. So yeah, that works.
Thank you, ma'am.
Thank you.
Extraocular surgery.
Making it intraocular.
Yeah, even with the chandeliers are the same thing. I mean, people are divided over it. But,
Okay, we can have the certificate distribution.
These things. Score sheets.
Dr. Santosh be there?
Yeah,
Nobody. Dr. Mahesh Babu. Sir. Dr. Sudipta Mitra. With an endo illuminator. Thank you. Dr. Omkar, Dr. Niladri Saha. Thank you. Dr. Saha, to Dr. Somen Mishra, please. It should do it on its own. Mishra sir to Dr. Telan, please. Sir? Dr. Ayesha? Yes, speakers. Mishra sir? Dr. Ajay Arora, I think sir is not here. Dr. Narendra Verma? Yeah, Ajay Arora is here. Sir. Dr. Rita? Dr. Sudipta? Atul? Dr. Atul? मैंने रख लिया डॉक्टर अनूप डॉक्टर पुष्कर आप कैमरा किसी और को दे के आइए मिश्रा सर मिश्रा Dr. Kshitij. Group photograph after this, please. It's kept it over there. वहाँ पे रख के आ गए